at menopause, this link is still there, but attenuated. And then in later age at menopause, Lewy body disease really wasn't associated with more tau compared to not having Lewy body. Age at menopause did not affect the link between Lewy body disease and beta amyloid pathology. So again, we see a tau specific effect. But we did see an association with cognitive decline. So we saw that age at menopause amplifies the link between Lewy body and memory decline in these women, whereby among women who have Lewy body disease in their brains on the right panel this time, those with earlier menopause in the red show steeper cognitive decline compared to both those with average and later menopause, as well as compared to women who did not have Lewy body disease. Together, these findings I've shown you suggest broadly that earlier age at menopause confers additional vulnerability to some of the key risk factors that drive Alzheimer's disease. And this is evidenced by the stronger links we saw between synapse degradation and Alzheimer's disease, vascular risk and Alzheimer's disease risk, and Lewy body disease and Alzheimer's disease risk, all in women who have earlier rather than later age at menopause. This might be because earlier menopause represents this extended period of estradiol deprivation in the body and the brain, which could drive heightened vulnerability to Alzheimer's disease pathological processes. And it could also be because early menopause is generally a manifestation of accelerated biological aging that increases women's vulnerability to a lot of different age-related diseases, including dementia, but not limited to dementia. And this could be via upstream factors such as genetics that influence things like inflammation and oxidative stress. So while the jury's still out on the mechanisms exactly, I think that these findings show that understanding dementia risk and Alzheimer's disease risk absolutely requires the consideration of female-specific hormonal factors across the lifespan, with midlife and menopause specifically being a critical window for women's brain health. Thanks so much.
Okay, can the people online hear us?
I hope so.
So
They should be able to.
is there
Yeah, we can hear you.
Yay, thank you, Zachary. That was Zachary. Any questions from? I think very quick one while Tallinn Splinter comes up would be and you sort of alluded to this, but do you think that earlier age of menopause is a proxy? Like what else might cause earlier age of menopause?
I do think there's some evidence for risk factors like physical inactivity and smoking and things that are, might be bringing that age at menopause forward a little bit. And those things could also be conferring greater risk for dementia. But I really think that doesn't explain all of it. I think that estradiol is really, really important in the brain. And I do think that the loss of some of those neuroprotective effects over an extended period of time could really be driving some of these things. But I don't want to discount also like the kind of upstream factors such as genetics and things like that.
Yeah. Great, thank you. All right, up next is Tallinn Splinter. I'm not, do you know how to work the thing? With the next slide. There you go. And Tallinn Splinter is a first-year master's student, so be gentle on her, I've been asked to say. And she's also at the University of Toronto at Sunnybrook Hospital with Dr. Jennifer Rabin.
Hi, so I'm Tallinn, as she said, a first-year master's student at the Rehabilitation Sciences Institute. And I'm just going to be talking a little bit today about the combined influence of earlier menopause and cardiac function on brain health. Sorry. Sorry. So I just want to start off by saying that women are at increased risk for cardiovascular disease burden and Alzheimer's disease risk, where cardiovascular disease is a leading cause of death for women globally, and women have a greater lifetime risk of Alzheimer's disease. 2/3 of Alzheimer's disease patients are women, and they also show greater cognitive decline and greater neuropathology within Alzheimer's disease compared to men. Therefore, examining female-specific factors such as menopause are really important to understand what factors might be contributing to these increased risks. And then unfortunately, as I'm sure a lot of you know, female health is very understudied. So this graph is showing a study that I did during my undergrad, where we saw that even though 70% of studies in neuroscience and psychiatry are using both sexes, only 5% actually examined these sex differences. And there's 9 times more studies in male health compared to female health. And this bias exists also within grants and funding, where CHR is one of the major funding sources within Canada, and only 7% of grants go towards female health. And this relates to only 0.8% of grants going towards cardiovascular disease in women, and only 0.08 going towards Alzheimer's disease and all other dementias in women, and only 0.4% of grants go to menopause. So we're really missing a big chunk of the research here. Menopause is a major inflection point of aging. It's a significant endocrine transition that usually occurs within the midlife, around 51 years of age. And it's characterized by the depletion of ovarian hormones, including estradiol and progesterone, and the increase in pituitary hormones. It's also important to note that there's many different characteristics within menopause, and factors such as age at onset or menopausal hormone therapy or type of menopause like spontaneous surgical can all influence your disease risk differently. So it's important to consider those factors when you're looking at menopause. So menopause is associated with some adverse brain outcomes, including decreased gray matter volume. So this graph on the right is showing you decreased temporal gray matter volume and baseline to follow-up during menopause. And it's also associated with an increased amount of white matter hyperintensities, which can be seen as lesions on an MRI. So this image on the right is just showing you what that may look like. There's also a sex difference within white matter hyperintensities, where this graph is showing you age on the x-axis and then white matter hyperintensity load, where there is an inflection point around the age of menopause, where women in blue show a greater amount of white matter hyperintensity load compared to men in red. So overall, this can lead to faster cognitive decline, increased risk of dementia, stroke, and mortality. So you saw this graph earlier from Madeline, but it shows that earlier age at menopause is associated with increased risk of dementia. So this is showing you age at menopause on the X and then increased risk of dementia on the Y. You can see that earlier age is associated with an increased risk. And this is the same within cardiovascular disease. So this graph is showing you the same thing as before, but cardiovascular disease risk on the Y instead. And you can see earlier age, you have an increased risk of cardiovascular disease. So earlier age at menopause is really obviously an important thing to look at. And work by Madeline, which she just showed, shows that vascular risk is associated with lower cognitive scores at follow-up and earlier menopause in pink, but not so much in the later ages of menopause. But this is for vascular risk. What about cardiac function, which is more what I'm interested in? So you do see that poor cardiac health does increase the risk of dementia in both men and women. So this graph is showing you impaired cardiac function in red and normal in blue. And you can see with impaired cardiac function, you have an increased incidence of dementia. And as I said, this is in both men and women, but what about for women especially and in terms of menopause? Which led us to the question, does earlier menopause exacerbate the impact of poorer cardiac function on cognitive and brain health outcomes in postmenopausal females? So to do this, we used 2 interconnected databases, the Ontario Health Study, which gave us women's reproductive factors, including age at menopause, and the Canadian Alliance for Healthy Heart and Minds, which gave us cardiac MRIs, brain MRIs, and 2 cognitive scores. So the cardiac functioning score that we use is called resting left ventricular ejection fraction, which is essentially a measure of the heart's pumping efficiency. It's how much blood the left ventricle pumps out with each contraction. And generally a higher percentage equals to better functioning, but extremely high values can be indicators of a hyperdynamic state or certain heart conditions. So this schematic on the right is just showing you what those percentages might mean. So overall, we included 701 postmenopausal females. They had an average age of menopause of 51, which is the same within Canada. And they had a range of that ejection fraction, that cardiac functioning score of 45 to 80%. And we did exclude any participants with left ventricular ejection fractions above 80%. As I said, it could be indicators of certain heart diseases. We wanted to control for that. And then 95% of our sample was white, which can limit the generalizability of these findings. Okay, we're having some technical difficulties. Okay, so we found that earlier age at menopause strengthened the associations of lower left ventricular ejection fraction with reduced gray matter volume. So you can see earlier menopause in pink here, and with the reduced cardiac functioning, you see lower gray matter volume, but not so much in average in yellow or later menopauses in purple. We then did a Johnson-Newman floodlight analysis, which essentially determines which range of menopause ages this association between lower ejection fraction and reduced gray matter volume was significant for, and we found that it was significant in menopause ages below 49 years. We found very similar results in terms of white matter hyperintensities, where earlier age at menopause, again in pink, and reduced cardiac function on the left is associated with an increased amount of these white matter hyperintensities, but not so much in average menopause, again in yellow, or later menopause in purple. And we did the same analysis and found that this association was significant for menopause ages below 45. And although we saw significant results in both the gray matter volume and the white matter hyperintensities, our results on cognition were not significant. So just to conclude, earlier age at menopause and reduced cardiac function may have a compounding negative effect on brain health. And these findings really underscore the importance of integrating sex-specific and female-specific factors such as age at menopause into investigations of risk factors for dementia.
Hey, well, we have time for maybe one quick question before we go to Katie Vandeloo.
Factors that influence the right ventricular injection, left injection. Yeah.
What are the factors?
Like, what would make someone vulnerable to that?
That's a great question. I'm not really quite sure about that, to be honest. I would assume factors that influence any of your cardiovascular risk factors and things like that.
Yeah.
Such as exercise and things like that.
Right.
But I honestly, that's great. I have no idea.
I'm honestly just thinking about myself. Really not.
Yeah, because yeah, well, I won't ask you a harder question. And also, we've already had one question, but I noticed that later age of menopause actually kind of went opposite way with
That we did look at the slope, and it's not significantly different from zero.
you.
So we did look at that.
Okay. Okay, thank you. Sorry, I gave you a second question. Katie Vandeloo, please come up. Thanks. All right. Katie Vandeloo is also at Sunnybrook Research Institute and the University of Toronto, completing her master's degree in clinical psychology. And I just heard she actually has a first master's degree in what? What was it in?
It was in neuroscience.
In neuroscience. Okay, thank you. Take it away.
Thank you. Okay, thank you so much for having me. So today I'll be talking about an investigation of the role of menopause in brain health and cognition with age using latent profile analysis. And you got a lot of background from Madeline and Tallinn that I will also be repeating some of, but I'm kind of looking at things in a little bit of a different light. I'm new to this area a little bit, but it's very exciting to me, and I'm also new to this analysis, but hopefully you find it interesting. So for many women, spontaneous menopause occurs around midlife with a median age of 51 in Canada, according to the Canadian Longitudinal Study on Aging. However, we know that menopause can occur much earlier in some women, depending on a variety of factors. During the menopause transition, we know that there is a decline in estrogens, including 17-beta estradiol, which can broadly impact the brain through changes in things like synaptogenesis, as well as glucose metabolism, changes in neuron morphology, etc. Menopause is also associated with a rise in chronic low-grade levels of inflammation, which is thought to propagate to the brain. So given this information, the fact that many menopausal symptoms are neurological in nature, including vasomotor symptoms and sleep disturbances, menopause can be considered possibly as not only a reproductive transition, but as a neurological one as well. Evidence suggests that estrogen is neuroprotective and that the loss of estrogen through menopause can influence brain structure, including global and regional gray and white matter volume. Cognitive changes are also common during the menopause transition. However, there is, hopefully I don't have an issue with this as well. However, there is a lack of consensus on how brain and cognitive changes present together in postmenopausal women, with some studies showing changes in both of those things, some kind of showing one or the other, or some showing none at all. So why does this matter? You've heard from Madeline most predominantly that, that 2/3 of individuals with Alzheimer's disease are female, and postmenopausal females account for over 60% of cases. And as the other speakers have prefaced, the menopause transition has been implicated in Alzheimer's disease risk. So postmenopausal females show greater Alzheimer's disease-related pathology burden accumulation in the brain, and earlier age at menopause is associated with greater Alzheimer's disease-related pathology accumulation as well, compared to premenopausal females and age-matched males as well. Sorry. Okay. It's also notable that females who experience menopause earlier than the average age appear to have greater Alzheimer's disease-related pathology burden in the brain, as I've mentioned. And then earlier age at menopause can also interact possibly with other risk factors, including vascular risk, to predict lower cognitive scores over time, which is work from Madeline in our lab. It's therefore possible that earlier age at menopause can contribute to Alzheimer's disease risk in some women. Okay. So often the study of brain behavior relationships are correlational. However, to improve clinical relevance and potentially address inconsistencies in the literature regarding brain health, cognition, and menopause, we might wish to reach for more person-centered approaches that consider individual data points to uncover information that group averages might fail to capture. Person-centered approaches differ in that they do not assume all individuals are drawn from the same sample, or the same population, and instead they consider the possibility that samples can include various subpopulations that are characterized by different parameters. And this is especially important as samples become increasingly diverse with respect to things like race, ethnicity, cultural background, gender identity, etc. So for example, latent profile analysis, or LPA, considers individual data points to identify data-driven subgroups of individuals who share similar characteristics based on variables of interest. So given that information, I decided to do a focused analysis of brain health and cognition in postmenopausal women using a more person-centered approach. And my objectives were to first define latent profiles of brain health and cognitive function in postmenopausal females using latent profile analysis, or LPA. And then from there to investigate how menopause-related factors related to latent profile assignment. To do this, I included 74 postmenopausal cognitively unimpaired females aged 55 to 85 that were recruited from the Canadian Multi-Ethnic Research on Aging, or CAMRA study, at Sunnybrook Research Institute. And CAMRA is an ongoing longitudinal observational study of risk and protective factors for dementia in a multi-ethnic cohort of older adults. And this primarily includes South Asian, Chinese, and white individuals. And this analysis included only baseline data. Okay, so first I conducted the latent profile analysis in R to define latent data-driven subgroups based on a variety of indicators. And this primarily included indicators of brain health and cognitive function. So for brain health measures, I used FreeSurfer to parcelate whole brain gray and white matter volume, as well as total white matter hyperintensity volume. And these are defined as lesions within the brain's white matter that tend to appear with age or degeneration. And then for cognitive function, I included experimental eye tracking based measures of executive function, processing speed, and episodic memory as well. And my justification for using this approach is that these tasks are intended to be linguistically and culturally neutral measures of cognitive function, which is important given the diversity of our sample. And then finally, I compared profile assignment before and after the inclusion of age at menopause onset as an indicator to see how information on age at menopause onset would cluster with patterns of brain health and cognition. And to determine the ideal number of profiles, I looked at model fit statistics, including Bayesian information criterion and entropy. Okay, so in terms of the overall sample, individuals were approximately 66 years of age, with an mean age at menopause of 50 years. We had 67 individuals who entered menopause naturally and 7 that underwent surgical menopause. And then we had an approximately equal distribution of South Asian, East Asian, and white individuals, with 10 sort of falling in this other category. And this included individuals identifying as Southeast Asian, Circum-Mediterranean, Black, Latinx, and East Indian. And then mean years of education was around 16. So in terms of results through LPA, 2 dominant profiles emerged, including a less favorable brain health cognitive profile and a more favorable brain health cognitive profile. Overall, the less favorable profile had lower whole brain white matter volume, lower whole brain gray matter volume, higher white matter and hyperintensity volume, and then lower cognitive performance as indicated by measures of episodic memory, as well as processing speed and executive function. This was a bad time to have a lot of blending. Okay, so what was important was that when I included age at menopause in the LPA, earlier age at menopause clustered with the less favorable brain health cognitive profile, alongside an identical pattern of lower brain health and cognitive function as well. So following this, I conducted some preliminary linear regressions in R, and my goal here was to investigate associations between profile assignment, where brain health, cognitive function, and age at menopause were included as indicators, and variables that have previously established relevance to menopause. So this included vascular risk, as well as depressive symptoms and quality of life as well. So in terms of vascular risk, I quantified this using the Interheart Risk Score, which is a composite score of various indicators, including history of diabetes, blood pressure, smoking status, stress, physical activity, mood, diet, and waist to hip ratio. And then depressive symptoms are measured using the Geriatric Depression Scale, and quality of life was measured using the World Health Organization Quality of Life Older Adults module. Okay, so overall, individuals in profile 1 were older. They had higher vascular risk as measured by the Interheart Risk Score. They also had higher depressive symptom severity and lower quality of life overall. And despite being preliminary, these are variables that we'll continue to examine as we recruit a greater number of postmenopausal females in our sample and have a greater range of age at menopause. So in terms of a take-home message, earlier menopause grouped with a less favorable latent profile that consisted of lower brain health and cognitive function scores, and variables with previously established relevance to menopause were related to this latent profile. And then in general, of course, future research to better understand relationships between these variables could inform early interventions to support cognitive well-being in postmenopausal women, and I would recommend the incorporation of person-centered approaches.
Any quick questions while we transition to the online?
I think I missed, why didn't you put age at menopause as one of the covariates for your model?
So I included, that's a good question. I included age at menopause in the actual latent profile analysis. I wouldn't necessarily want to, like, possibly you could look at both, like maybe do a sensitivity analysis with and without age at menopause, but I wouldn't necessarily want a covariant take away possibly meaningful effects related to age at menopause with those specific profiles. So for myself, I would probably, rather than just covariant for it, maybe do one. But for this, I specifically didn't. I don't know. Would it be something interesting?
Right, now, first up online, we have Zachary. Yeah, we have lots of questions online too, which we'll get to hopefully at the end. Zachary from Plumley, and he's doing a PhD in Tulane University. Zachary, you'll have to unmute at some point too, and we have to stop sharing.
Yes.
All right, can y'all hear me okay? Can you guys hear me okay? I don't know if I can hear you.
We can hear you
Perfect.
online.
You can hear me online, okay. Can people in the room hear me? I don't know if I can hear people. I'm sorry. Let's see, I'm gonna check the chat here. You can hear me, okay, perfect. All right, I'll go ahead and jump in here. So I know we've been talking about person-centered approaches to understanding the effect of menopause on different changes, the interactions between vascular health and time of menopause. I think that's an interesting theme for our talks today because we're talking about this idea of precision-based medicine. At what point can we intervene, for example, with estrogen therapy, to make it the most beneficial for different women at an individual level? Ironically, I'm going to be talking about that from a mouse perspective. So we're talking about mouse models of menopause in my talk today. And I'll go ahead and jump right in for y'all. Let's see here. Turn on my laser pointer. So we know, as some of the other speakers have mentioned, that undergoing the menopause transition is associated with increased risk of metabolic disease and age-related cognitive impairment. That's been seen in rodent models of menopause, but also we've seen some indications in the human literature as well that this menopause transition is causing those increased risk, for example, of Alzheimer's disease, where 2 in 3 diagnoses of Alzheimer's disease go to women. We know that estradiol treatment is shown to be neuroprotective in rodent models of menopause. That includes ovariectomy and also the VCD model. Oh, pause. Something happened? Oh, you can't see. Oh, okay. Sure. Let me know if I should change anything with which screen I'm sharing, if that helps. It looks like people online can see.
You can see and hear online, Zach.
Okay. Are we good? You guys can still hear me okay and you can see the screen? Perfect. All right. I'm gonna jump back in, get my time going again. Um, we know that estradiol treatment is shown to be neuroprotective in rodent models of menopause. That includes ovariectomy models, which are these kind of like surgical models of menopause that we might have been talking about previously in humans, but we can also use surgical models of menopause in mice, along with chemical follicular depletion models of the ovaries. And let me see, results of menopausal hormone therapy still remain kind of ambiguous as to whether or not estrogen can be neuroprotective for all women. And that's evidenced by findings from the Women's Health Initiative, which was, of course, very controversial. We know the timing of menopause and the timing of estrogen treatment to be really impactful as to the benefits of estrogen therapy. But one thing is that we were thinking about our group is whether or not the presence of pre-existing metabolic conditions or cardiovascular disease before menopause might be preventing some women from getting the best possible chances of the benefits of estrogen treatment. We know that in mice, for example, most studies of ovariectomy and estrogen treatment are given chow diet ad libitum, which is a fairly healthy balance of fats, proteins, and carbohydrates. But we know that in women, women arrive at menopause with a variety of pre-existing conditions that might be moderating the effect of estrogen therapy. Something that we looked to test is whether or not something called neurovascular coupling, which is moderated or altered in rodent models of cardiovascular disease and menopause, whether or not that is something we can use as a unit of measurement to check the sensitivity of the brain to estrogen treatment following menopause if we induced a metabolic dysfunction prior to ovariectomy. And you can see here that there are penetrating arterioles branching off of the middle cerebral artery. This is in the human brain, similar to the mouse brain, and capillaries deep within the brain that perfuse and provide oxygen and nutrients. We started to think, okay, well, what if we took a look at if we stimulated mouse whiskers, could we look inside the brain, see dilation of these blood vessels in response to whisker-induced stimulation? And for example, the somatosensory cortex, which responds to whisker tactile sensory information, and then test whether or not in the presence of a metabolic disease or in the presence of estrogen therapy, if there are going to be interacting effects. And our question was, does the efficacy of estrogen therapy depend on this metabolic health status at menopause? Our hypothesis for this project, which I'll show you in the next slide, is that pre-existing metabolic dysfunction might blunt the effects of estradiol treatment on neurovascular coupling after the onset of menopause. To induce a metabolic dysfunction, we use a 60% calories from fat diet given to mice randomly assigned to either a controlled diet or high-fat diet for 11 weeks. We implanted cranial windows atop of the somatosensory barrel cortex of the mouse brain. So just a little window right over the top there. And we use a type of imaging called intrinsic optical signaling to take a look at which areas of the brain actually respond to whisker stimulation so that we know exactly where to look. Something important here is a theme we've also been talking about, looking at middle age and the timing of menopause. We're looking at a middle age model of menopause in female mice. So at about 10 and a half months of age, we ovariectomize them. But prior to that, we get a baseline assessment of that neurovascular coupling. And then we complete a post-ovariectomy neurovascular coupling assessment. Right after ovariectomy, we give them either a vehicle or estradiol capsule placed underneath the skin to essentially replace estrogen at a tonic mid to high physiological dose. And of course, over the course of this induction of metabolic disease and after menopause, we complete metabolic assessments such as glucose tolerance tests and DEXA body composition scans to get an idea of whether or not the metabolic dysfunction is sufficient enough to elicit an effect and what those metabolic phenotypes are looking like after estrogen therapy. And then we collect tissue. So to look at the neurovascular coupling of these penetrating arterioles, we use something called in vivo two-photon microscopy, where we can take cross sections of these penetrating arterioles about 50 microns beneath the surface of the skull and get images of penetrating arteries as we stimulate animals' whiskers with a little air puff. And you can see there's baseline diameter here. Once we start the whisker stimulation, we get a nice dilation, increasing blood flow to that area. And then it kind of plateaus back to baseline after. You can see our little mouse here attached, head fixed to our two-photon rig, little pico spritzer here, which elicits a 4 hertz puff of air for a period of about 8 to 10 seconds. Over the course of our paradigm, you can see our imaging. We've delineated the area of the brain that's responsive to whisker stimulation, so we know to select penetrating arterioles within this defined region. This is an image of a penetrating arteriole going about 50 microns beneath the cortical surface, and we go and we look for these guys. On this side, you can see at baseline, the baseline diameter, and after whisker stimulation. And in magenta here, you can see a MATLAB quantification of that increase in diameter after whisker stimulation. And then we quantify it all. So if we take a look at some of our results, just checking my time here, we see that our estradiol treatment was sufficient to induce uterine horn hypertrophy, which is kind of a way that we can just make sure that, number one, that OVX is a model of depleting endogenous estrogens, and also that if we give estrogen back, it's sufficient to induce this hypertrophy. It's physiologically relevant treatment. Body weight, at the end of the study, we see that the mice that fed high-fat diet had an increased body weight, but those that were given estrogen on the high-fat diet had weight loss. When it comes to tissues, we have heart weight and kidney weight. We did see cardiac hypertrophy, indicating that the high-fat diet caused the heart to get larger. That could be just due to the size of the animal, or it could potentially relate to hypertension or stress of the heart. But kidney weight, we did see no differences there. Take a look at our metabolic dysfunction model. Just checking the chat to make sure I don't have a message there on time. We have our glucose tolerance test, where we can see that at the post-OVX time points, this is after animals are given estrogen or vehicle, we see that mice given the high-fat diet had increased fasting glucose levels, which were rescued by estrogen treatment. And then if we just take a look at the whole area under the curve of this glucose tolerance test, you see that mice on the high-fat diet given vehicle are not able to successfully retrieve glucose from the blood as well as those that were given estrogen. And this kind of goes along with some of the previous human data on the effect of menopause on metabolic disease risk factors. We also see increased adiposity with the high-fat diet, which makes sense. But if you give estrogen back, we see that that fat is decreased. So it's essentially preventing the increase or accelerating the loss of fat when you give estrogen after menopause. No changes in lean mass, suggesting that that body weight difference we saw earlier is exclusively due to the fat loss. Now, when we get into the neurovascular coupling data, we see that there's no effect observed of the high-fat diet on the dilation of those penetrating arterioles. However, what we can see here is, I think I have my 1 minute. All right, perfect. We see here that estrogen is actually potentiating that neurovascular coupling response. So when an animal is getting those air puffs, regardless of the diet the animal is receiving, we're seeing a significant main effect of estrogen across the board. And like the previous pre-OVX baseline measurement we saw before, we're seeing that at the post-OVX time point, there's still no effect of high-fat diet uniquely. So this is suggesting that metabolic dysfunction does not moderate the effects of E2 on neurovascular coupling, at least in penetrating arterioles, even though we do know that our high-fat diet model is inducing this like peripheral metabolic dysfunction, that it's not enough to alter the penetrating arterioles. And that could be due to a number of factors that we could get into later in discussion. But this is an interesting finding that we can see that regardless of the diet, estrogen is still potentiating these animals' responses to whisker-induced vasodilation in the brain, suggesting that maybe certain parts of the cerebrovasculature have an underlying evolutionarily conserved mechanism to get that brain perfusion. And here are some of my acknowledgements. I work as part of a large team. The main people helping me out on this project are Jenny, Irene, and my PI, Ricardo Mustani. But we work on a program project grant here at Tulane, 4 different labs, all studying this question of what factors, health factors, contribute to whether or not a mouse will get the benefit of estrogen therapy in a model of menopause. So you can follow our project here if you'd like to take a scan.
No, they can't.
Thank you so much, Zach. Can you hear us?
I can hear you.
Okay, great. Let me just turn on the sound. Sorry, everyone. Just a few issues here. All right, do we have a question for Zach?
Yeah, I have a question, Zach. I'm going to take chair privileges and ask you a question. Because I noticed that estradiol you saw some changes in the heart itself. And
Yes.
didn't change it, but did the neurovascular coupling. So What do you think about that? It has neural effects, but not peripheral.
Well, it's the opposite. It has the peripheral effect. Or sorry, you're talking about estrogen. The
Yeah.
estrogen did have an effect. If we go back, let me scroll
Okay.
back here. It did not on the heart itself,
No,
but
that's
but if we look at sorry, I'm gonna have to pop through here. If we look at the metabolic dysfunction model, we saw that estrogen actually rescued the hyperglycemia associated with the high fat diet,
right. No, I
along
know
with,
peripheral parts.
oh,
I meant more
oh,
on the heart.
on the heart, yes.
On the heart specifically.
You're right. Yeah,
Hormonal
here
effect on
there
that.
was that main effect of the diet, but yeah, estrogen didn't seem to moderate that or didn't rescue that effect.
Maybe it's just because it's a
Um,
bigger measure, grosser measure, and if you looked.
I think so too. Yeah, we'd have to kind of get a little bit more like granular, maybe to look at maybe levels of hypertension, or one of my colleagues here looks at arterial stiffness and hypertension and things like that to get a better indication of what's happening in the periphery and also the heart.
Okay, great. Thank you so much, Zachary.
Yeah, no problem, y'all. It's a pleasure.
And thank you for bearing with us with this hybrid situation. Next up, we have Marta Kobushevsky. And she is doing a PhD at UBC, my old place of business. So, Marta, so we're talking about biopsychosocial predictors of sexual function in menopause, a systemic review. Marta, whenever you're ready.
Okay, can you see my screen?
Yes,
We can see it.
give us 2 seconds. I'm just going to put your sound up in the room, Marta.
Okay. There we go. Is the sound good? Yeah. Okay. Awesome. Thanks so much for having me. Yeah. So I'm going to be talking a little bit about an ongoing systematic review that we're conducting here across a few labs at UBC and at the Université du Québec en Outaouais. And it's looking at biopsychosocial predictors of sexual function in the menopausal transition. So the menopausal transition, so that's that shift from the reproductive stages to postmenopause, is normative, it's widely experienced, but a lot of individuals who are transitioning through menopause are really underprepared for the changes that menopause brings. And these concerns are particularly common among perimenopausal individuals. So that's kind of colloquially what we refer to as people who are going through that menopausal transition of that variability in menstrual cycles and up to 12 months after the final menstrual period. And among the most common changes in the menopausal transition are changes to sexual function. And so sexual function refers kind of broadly to both physiological and psychological processes implicated in sexual response. And so clinically, I'm a clinical psychology trainee, we often categorize these processes into kind of desire, arousal, orgasm, and pain. And so desire is this subjective experience of having interest or wanting sex. Arousal includes both subjective feelings of pleasure as well as the physiological experience of arousal. So that's things like vasocongestion, lubrication, erection of tissues. There's orgasm, which is climax. And then we also have problems with genital pain and discomfort. And that's specifically in the context of sexual stimulation. And so a diagnosis of sexual dysfunction just involves one of these problems plus distress. And what we see is that problems with sexual function are really, really common in perimenopause. Up to 78% of individuals in the transition to menopause report some kind of problem to their sexual function. It's not always severe enough to meet criteria for sexual dysfunction, but it does mark a notable change from their sexual function pre-menopause. And this high prevalence of sexual function problems in perimenopause highlights the need to better understand modifiable protective and risk factors that can help people's sexual function as they transition to menopause and beyond. And so one way that we often think about these factors is through the biopsychosocial model. And so the biopsychosocial model of sexual function looks at how biological variables, psychological variables, and social variables all predict sexual function problems. And there's a lot of research looking at the biopsychosocial model pre-menopause, as well as a pretty solid amount looking at the postmenopausal period. But perimenopause specific predictors are less understood. There's just less research on this perimenopausal time. And so what we were interested in our systematic review was looking at the literature out there that examines biological variables. So that's hormonal changes, urogynecological symptoms, vasomotor symptoms, things like that, as well as psychological variables. So things like mood, depression, anxiety, brain fog or cognitive changes, and self-esteem, as well as social factors. So things like life stressors or relationship and partner factors, and how these all work together to predict sexual function in this time period. And so our research, this is my little methodology chart of what we did for the systematic review. I'm not going to jump too into detail with this because it's not that exciting, but essentially we identified over 7,000 papers that could be relevant and narrowed it down to 45 that we ultimately included in our review. And so what did we find? Well, we first looked at things kind of broadly in sexual function, but we were also really interested in the specific biopsychosocial predictors for these different facets of sexual function. So we were interested in desire, we were interested in arousal, we were interested in orgasm, and we were interested in pain, because there's just distinct etiology and pathophysiology of these different sexual function problems. And so it would make sense that different factors predict them. And for desire, what we found was that in terms of biological factors, just experiencing urogynecological symptoms, so that's like vaginal dryness, things like that, were very strong predictors of not desiring sex. And then in terms of things like hormones, there were some small effects, but they were significant between testosterone and higher desire, as well as FSH and lower desire, which we kind of expected given that this is a proxy for the menopausal transition. In terms of psychological factors, what we saw was that depression and stress were some of the biggest predictors of low desire. And these were stronger predictors, in fact, than the hormonal or biological factors. And finally, in terms of social predictors, the most important protective factors for people's sexual desire in this menopausal transition were having a strong romantic relationship with their partner. So people who felt really satisfied with their relationship, people who felt that their partner heard them and listened to them, were more likely to experience desire for that partner compared to people who were in a poor relationship with their partner. And we saw similar results for arousal, although there were fewer biological associations. So we saw this relationship between FSH and lower arousal, and then there were equivocal findings for testosterone. So sometimes higher testosterone was associated with more arousal, but sometimes there were just null effects. Stress was associated with more problems with arousal. And then, of course, relationship satisfaction was associated with greater arousal. For orgasm, there were just very, very few papers that actually looked at orgasm. It was really telling that almost all the research looked at desire, and there were just a handful of studies that considered orgasm at all. But there were really mixed findings. And this might also have a lot to do with how these things were measured. Sometimes there were validated measures. Sometimes it was just a single item about orgasm. And the timing of like what time frame the measurement was on was also really, really mixed. So sometimes people are asking like, in the last week or two, have you experienced orgasm? Whereas other times the questions were asking just really broadly, do you orgasm, or how frequently do you orgasm? without necessarily saying whether it was with a partner, on one's own, or both. Finally, we looked at relationships with pain during sex. And here there were no associations with any of the hormonal measures. And there were only associations with vaginal dryness being the biggest one. Although once controlled for the use of lubricants, this association disappeared. And so what we found instead was that some of the biggest predictors of pain during sex were mood and depression, as well as simply engaging in sex. So actually engaging in sex more frequently was associated with less pain, although it may have been really distress about pain. It was hard to tell from how this one paper assessed things. And so in sum, we're still doing a little qualitative synthesis and the bias testing of this study. But we saw that some of the strongest predictors of sexual function problems in the menopausal transition were psychosocial factors. So hormones, including testosterone in particular, seem to have a modest effect on sexual health. But it was really things like depression that conferred the most consistent risk factor for problems in all domains of sexual function. And relationship factors were really important predictors of desire, arousal, and orgasm, but were less important for predicting pain. And so this takes us to some of the limitations. As I mentioned, our bias assessment is ongoing, but one thing we've noted is that just many of the studies didn't use validated measures of sexual function, or they sampled across reproductive stages, and findings particular to perimenopausal individuals were based on interaction effects, and so may not have been powered to actually find the effects in question. And so this brings us to next steps. For us and our team is just completing the synthesis and bias assessment. But in terms of guidance for future research, what we've seen to find so far really does suggest that there is a need for future research that focuses explicitly on the menopausal transition, uses validated measures, and employs prospective, longitudinal, and intensive sampling designs to better understand the relationships between various risk factors and sexual function outcomes. Thank you.
I can do the little clap emojis.
There we go.
It's always nice to see those. I'm gonna take chair prerogative again unless it's something. Oh no, Jenny, you have a question. Yeah, you go. No, go. You go.
I don't know if she can hear me, so maybe you can
can.
repeat
Oh,
it.
okay.
But
I can hear you. Sorry, I'm just like leaning right in.
I'll talk louder. So with respect to the depression outcomes, did you look at medications? Because sometimes or often medications can be associated with low libido.
Yeah, so we didn't see those usually accounted for. There were some models that did, like because it's a systematic review, but for the most part, people actually weren't assessing if people were taking like SSRIs or things like that.
Martha, they're all such interesting presentations, but we have one more. I want to make sure we have enough time for it. And yes, fantastic. Natalie, this is next up. I believe it's Dr. Natalie, and maybe Dr. eventually. But I don't know how to pronounce your last name. Is it Simon?
It's a toughie. It's Shime.
Chime. Oh yeah, I would never have gotten that.
Yeah, it's all good.
So, Doctor, do we get to call you that yet, or no?
Not yet. A couple years. Invite me back in a couple years, and then you can be Dr. Squared.
PhD. I'm not sure from where you have your PhD, but you're now doing your MD. Oh, maybe University of Toronto.
PhD from the University of Calgary, and then postdoc at the University of Toronto.
Okay. And now doing an MD. Is that correct?
Yes, that's correct.
All right. That's hence the doctor. I think I need to do an MD just to be Doctor. I'm gonna stop talking, and it's over to you.
Give us 1 second, Natalie, and I'll just make sure that we can hear you in the room.
Sure. Okay, go ahead. Excellent. Okay, thanks so much for that introduction. So I'm really excited to be joining from Calgary. As mentioned, my name is Natalie Shime. Currently, I'm a medical student by day and epidemiologist by night at the Alberta Sex, Gender, and Women's Health Research Hub. And I'm excited to share a study today that we recently published, and I finished at the tail end of my postdoc. Okay, and just to check, you're seeing my slides and not my talking notes. Is that right? Did I share the correct screen? Maybe someone online even could tell me. Yes, fantastic. Okay. Okay, so talking not about neuroscience today, but about breastfeeding, which has some implications for the brain. So breastfeeding is recommended as the best method for feeding infants and is often touted for its health benefits for children, but it actually has several health benefits for the birthing parents, for moms as well. Lactation physiology includes cardiometabolic effects like increased lipid metabolism and insulin sensitivity, which are thought to explain the associations we see between longer breastfeeding and lower risk of things like hypertension, heart disease, and diabetes in women later in life. Comparatively less attention has been paid to the reproductive effects of breastfeeding, which can be quite profound. So the hormonal profile of lactation suppresses the ovaries, and this stops estrogen production, ovulation, and menstrual periods. Lactational amenorrhea can actually be a reliable form of birth control for the first 6 months if certain criteria are met. Periods can take up to a year or more to resume, and breastfeeding moms can also experience things like hot flashes. So there really is this menopause-like state induced by the low estrogen of breastfeeding. These reproductive effects are thought to explain some of the associations we see between breastfeeding and decreased risk of ovarian cancer, and possibly of risk for endometriosis and size of uterine fibroids, which are common gynecologic conditions that are estrogen sensitive. But surprisingly, very little research has looked at whether breastfeeding influences menopause, which, as we've heard today, is directly linked to ovarian function. So the first study to look at this used the Nurses' Health Study in the US and found that, let me see if I can get my cursor here. I don't know if you can see it, but I'll try anyways. Longer breastfeeding was associated with decreased risk of early natural menopause before age 45. And the second study that was actually completed by our team used the Study of Women's Health Across the Nation, which is also in the US, and found no association between breastfeeding and menopause occurring between ages 45 to 60 years. So at first glance, you'll think these two studies are contradictory, but you'll actually notice they looked at different age windows for menopause. And when I see this, I always think, could there be a time varying impact of lactation across the full spectrum of ages where menopause can occur? You'll also notice that these two studies focused on natural menopause, and this highlights a gap in our understanding of medical types of menopause like bilateral oophorectomy and hysterectomy, which we know affect about 15 to 20% of women, maybe even more in Canada. Okay, there we go. So our team wanted to answer the research question, is lifetime duration of lactation associated with the timing and type of menopause that women experience across the spectrum of midlife aging? So for this study, we analyzed just over 19,000 Paris women in the Alberta's Tomorrow study. And this is a province-wide prospective cohort study that follows participants about every 3 to 5 years with comprehensive self-report surveys. So we only included women that had one or more live births and women that were aged 40 to 65 years at baseline, since over 90% of Canadian women are done having children by age 40. So we can reliably analyze the lactation history that they reported. Here are the sample characteristics. I'm sure it's a bit hard to read, but generally what we saw was that women with longer lactation more often had a later year at birth, more often had a university or postgrad degree, higher order parity, and reported never smoking. And conversely, they had a lower mean BMI and fewer chronic medical conditions. So generally, the women who breastfed for longer were younger and had better health profiles. And we see this a lot in observational data. And we did our best to control for these differences in our modeling. So we used a method that I love called the Flexible Parametric Survival Analysis Model. And basically what it allows us to do is look at whether the effect of an exposure changes over the follow-up time. So instead of getting just one hazard ratio summarizing the association between an exposure and an outcome over the life course, we get a series of hazard ratios. in this case, showing how lactation is associated with differences in risk of menopause at each age. And then I can plot these as a curve. So our comparison group was women who breastfed for less than 1 month. And then we had categories 1 to 3 months, 4 to 6 months, 7 to 12, and 13 or more months. And just to orient everyone, for hazard ratios, looking at the time to event of menopause, anything above 1 means greater risk or quicker onset of menopause, and anything less than 1 means decreased risk. So first, we found that longer lactation was associated with decreased risk of earlier natural menopause before about age 50, but then quicker onset of menopause thereafter. And this is really intriguing to us because one of the most common hypotheses for reproductive determinants of menopause is called the follicle sparing hypothesis. And the thought is that because females are born with a set number of follicles at birth, and these follicles are then lost through ovulation and apoptosis over time, anything that decreases the number of ovulations a woman experiences could theoretically prolong ovarian function and then delay the timing of menopause. This hasn't really come to bear, though, consistently in epidemiologic studies, including ours here, where there's not a true dose response effect. And for that, we would see that longer lactation just progressively delays menopause. But we're actually seeing a slight narrowing of the age distribution of menopause, centered around age 50 to 55 years. And this could represent a biological normal or optimal time for menopause in contemporary females. My slides are a little laggy. There we go. We also found that longer lactation was associated with markedly decreased risk of early surgical menopause from bilateral oophorectomy, and particularly early surgical menopause before about age 50. And this aligns with the evidence I mentioned earlier, showing breastfeeding is associated with decreased risk and burden of endometriosis and ovarian and endometrial cancers, which probably account for a sizable number of bilateral oophorectomies in early adulthood. Lastly, we looked at women who had a premenopausal hysterectomy. So the uterus is taken out, but the ovaries are left in. So they're no longer having periods, but their ovaries are still in, they're still functioning. We can no longer tell clinically when ovarian function actually stops. So hence menopause here is indeterminate. And we found that longer lactation was associated with slightly decreased risk of indeterminate menopause before age 50, which again aligns with that evidence on the protective effects of breastfeeding for gynae conditions. But we also found that longer lactation was associated with a slightly higher risk of indeterminate menopause after age 50. And this was a bit puzzling to us, but one hypothesis we have is related to the change in indications for hysterectomy as women age. So when women are younger and less than 50, we see a lot of hysterectomies for things like endometriosis, fibroids, abnormal uterine bleeding. But as women age and go past 50, we're seeing a greater proportion of hysterectomies for things like pelvic organ prolapse. So one thought we had, and it's really just a theory at this point, is that the low estrogen state of breastfeeding perhaps impairs the repair of the pelvic floor after birth. Another thought is that labor factors that both promote breastfeeding and are associated, that promote breastfeeding like vaginal birth may damage the pelvic floor. So we're thinking about something related to pelvic organ prolapse being a mechanism here, but there's still lots to disentangle. So we're hoping to actually link this cohort with health administrative data in Alberta and try to track down women's childbirth records and see if we can explore this a bit further. As many of the other presenters have mentioned, early natural menopause, surgical menopause, and premenopausal hysterectomy carry important health risks for females, including higher risk of vasomotor symptoms, cardiovascular disease, cognitive impairments, and premature mortality. And our study really excitingly shows a potential novel benefit of breastfeeding for women through reducing these adverse menopause characteristics and their downstream risks. There are, of course, limitations to consider here. Any study about long-term effects of breastfeeding is observational, so a key challenge here being unmeasured confounding. So we know that social advantage and a healthy lifestyle are strongly associated with breastfeeding, but also associated with better health during menopause. So we did control for these factors where possible, and our team is really continuing to brainstorm ways that we can try to triangulate causality in these observational data. These findings, however, do suggest that scaling up healthcare policies shown to improve population breastfeeding rates could help optimize the type and timing of menopause women experience in midlife. So it could be a really useful upstream approach to then optimizing women for when they go through menopause. Thank you very much. As I mentioned, this is a published study, so there's a QR code here. It's an open access paper if anybody wants to read further. Thank you.
We should be able to hear you now. Yes.
Yeah, I can hear.
Pete.
Oh, okay. I have a question then for you, Natalie. I can only see your eyes, but that's okay. The eyes are the window into the soul, right? So, did you look at? I think you did talk about it a little bit, but I'm wondering how much time. So you have a look at lactation time, and you split it into 1 to 3, 4 to 6, 7 to 12. And then I was trying to mentally figure out where I would have been, and I think you also showed that the more children you had, the more lactation time. So did you add them all up?
Yeah, so that's sort of the concept of lifetime duration. So you add
what? I can hear you, but I bet it's a great answer. And also, when you answered me, can you did you look at like the timing between? You could look at that as well. So maybe it's like within 3 years of each other or something like that. You know what I mean?
Yes, the timing between pregnancies, you mean?
So you add them. No, sorry.
Can you hear me?
Perfect.
Okay. Yeah, so maybe I'll answer your second question first. So if you're talking about the timing between pregnancies, we unfortunately didn't have data on what year they gave birth and or what year the pregnancies were, how old they were. So that's something we are trying to track down though with the childbirth records. I don't think with this cohort we will get complete childbirth records just because they're a bit older and administrative data generally only goes back to the 90s, but we're going to give it our best effort and see what we can figure out because I think that's important and there's a lot of nuance here. Your first question was about how we get the categories, I think. So yes, what the question was posed to participants was adding up the number of months you breastfed over all your live births. How many months did you breastfeed for? So it's cumulative. So of course, if somebody had 2 births, potentially their breastfeeding time is much longer. One thing we did do though, is we did a sensitivity analysis where we restricted all of these models to women who had 2 live births because that was the largest group in the sample was the P2 ladies, and all of these associations held. The precision was a bit worse just because it's a smaller sample size, but we were still seeing all of the same trends and findings, which was really interesting. And we did control for parity in the main models as well. So we tried to tackle parity a few ways, but it's always a challenge when you're looking at lactation. Like, do you analyze it, duration of time spent breastfeeding per birth? Do you do it overall? There's different pros and cons to each, but a great question. Thank you.
Well, thank you. Thank you to all of you. I don't know if Emily Ann wanted to do closing remarks.
There might be a few. I'm just looking through the chat to see if there's any other questions.
I'm sure there are quite a few. I saw some popping up. But maybe what we can do is send around, because it's our first hybrid event in a while. So maybe what we can do is send around questions to all of the speakers afterwards, and maybe we can even have like an online discussion. Doesn't have to be like in real time, but like a little blog Q&A kind of. That could be fun.
We have a couple questions.
Okay, sure.
So this first question is from Michelle. This is for anybody who would like to answer. Has there been an association between symptoms reported by women in studies, hot flashes, vaginal dryness, brain fog, night sweats, etc., and LBD and AD outcomes? Not sure if this was measured in any of the studies. Thank you.
Yeah. There's not that much research on it. There's a little bit. Most of the time. Sorry, I'm just answering it because we're actually at time, so but would you say you guys?
There was one study recently showing that vasomotor symptoms are associated with higher plasma biomarkers of AD pathology,
I just saw
which is really cool. But super limited research. I'm sure there's nothing for LBD yet. But yeah, definitely an avenue for exploration.
And maybe this is the time to also say, you know, it's ignored so much in the literature, and Tallinn Splinter showed that it was 0.4% of grants are going towards that in Canada. But you can also see that reflected in publications. It's under like 0.1% over the whole time. So imagine, you know, we're talking a lot about age and menopause because those are the kinds of variables we have. But for vasomotor symptoms or any other menopausal symptoms, there's just virtually, I would say nothing, but almost nothing out there. And so that's why we need policymakers, researchers, funders. Oh, I said that already. Yeah, funders, politicians. We need that advocacy to do more of this research so we can present more of that data. And I know there's more questions, but we are out of time, I believe.
Yes.
So thank you so much to everyone who came here. I'm sorry, people online, we have cookies. You don't get cookies. We can mail them to you though. And please join us again.